has become a behavioral scientist as well as all the other things he does. So we'll just open it up to the panel and then to the audience over the next 25 to 30 minutes. King, do you have any comments on what you, or David as well, on what you just heard?
So I thought all of the presentations were brilliant, and I thought it's a lot to grasp all of this stuff in a short time. I liked your inclusion of the life stages in terms of how these patterns or perspectives may evolve over time. And I like that you were beginning to link towards the end how these ideas about sexual behavior may relate to different sexually transmitted infections, some of which you didn't get into the crab lice. I was a little disappointed in that. As all of you know, there is a behavior that has changed the ecology of the transmission of crab lice that I'd like Sevgi to explain to all of you.
I'm sorry, but you'll have to teach again. What behavior is that?
I'm happy to do so, but it's maybe Tom Quinton should be the one who does. But anyway, how it relates to how these behaviors that you're describing relate to infectious diseases of high-level, low-level infectivity, the gap that you like to talk about, where the period of infectivity may be very high for short periods of time, and then, as with chlamydia, persists for long periods of time with lower infectivity, and GC and so on. So maybe you could say a little bit more about that.
So what comes to mind immediately is, of course, infections like gonorrhea, chlamydia. Short-term relationships are very important. So sex work is what we would study a lot. And one-night hookups would be what we would study a lot if we are looking at those kinds of infections. When you start moving towards herpes, HIV, etc., long-term sexual partnerships become important. I'm not sure at this point we have sufficient data to really start talking about the trajectory of multiple long-term partnerships. We do know geographically there is great variability from one place to another in those patterns, but I'm not sure we can talk about, what things were like in the 1950s in Africa. What are they like today in Africa or in Europe or in Asia? This is a field which is still growing, and we will get there, I think. Yeah. But we are not there yet, as far as I can see.
You emphasized the sex tourism as it was affecting linking between women in particular and heterosexuals, but didn't say much about how sex tourism may be affecting same-sex behavior among men. And when I was listening to David's talk, and we had both spoken about how the evolution of the introduction and spread of resistant sexually transmitted infections like gonorrhea seem to be occurring along a specific geographic pattern and according to sexual orientation among men, how that may relate to sexual tourism, for example. Have you looked at that in relationship to the U.S. And men going to Asia, for example, Thailand, et cetera?
No. However, we have had the first meeting, David, Jamie Blanchard, and myself, and talked about working towards a paper which will look at exactly that. We'll get there, King. We're not there yet.
Sevgi, is the right tail and the core groups, are they just different phrases for the same population, or are you used them both and I wasn't?
I use them interchangeably. The right tail is when you're looking at numbers of partners, the people who are at the end of the curve. Core groups are sex workers and very highly sexually active, I don't know, adolescents, for example. But really, I think if you put the sex workers or the highly sexually active adolescents on a curve, they would end up in the right tail of the distribution, I think.
Thank you. Other comments from the panel? Hunter here is going to give us a good question or maybe an answer. Where do people have to go to ask up to the?
No, not.
Thank you.
Is this on?
Yeah.
Sevgi, that was a superb presentation. I'd like to take you to a slightly higher plane. So there's been an emphasis, increasing regard for sexual health as a formulating, as a driving concept of what we do in our field. And the American Social Health Association has named it, even changed its name accordingly. I can see some positive outcomes from the trends you have described, in fact, many of them. Would you care to speculate on that balance? When you put together all of what you've described and consider that there are some benefits to improved sexual happiness, liberation, different attitudes that are penetrating, if we pardon the expression, into a lot of societies, where's your balance? And what's in terms of sexual health overall versus the effects on STI and other downsides of sexuality?
Yeah, it seems like if we're talking about psychological sexual health, all of these developments probably end up being quite positive for people's psychological sexual health. But so long as these behavior changes are happening without changes in, for example, condom use, I don't see how they will be good for sexually transmitted infections. Because what I know about condom use is even under the best of circumstances, you have a lot of condom use at the beginning of partnerships. But as soon as you get to, I don't know, a month or even shorter duration, condom use gets dropped. So when you have all these multiple partnerships, I'm not sure how STI will be contained. I'm actually amazed that we don't have much more explosive spread of sexually transmitted infections given these patterns in sexual behaviors. But psychologically speaking, socially speaking, in terms of issues of shame and morality being brought into people's behaviors, I think that's where the positives are.
Please.
Yes, I wanted to ask whether you felt that if there were changes in the status of women, whether that would have any effects on the rate of these infections, particularly if the person has, women have increasing financial resources or power in terms of, expectations of use of condoms, or where it's clear there are campaigns to try to prevent STDs.
Thank you. Status of women is a very important determinant of all kinds of things in societies, and I do expect as status of women goes up, there will be a favorable impact on sexually transmitted infections. The problem is there are all kinds of inequalities in societies. Gender inequality doesn't come by itself. Every place we have social class inequality or income inequality. Now, I grew up in Turkey thinking there was no gender inequality. I'm serious. I grew up in a certain socioeconomic bracket, and I saw no gender inequality. I came to the United States, everybody started asking me about women in Turkey, and I said, what do you mean? The person who teaches sociology just like I do, who's male, makes almost twice as much money as I do. This is where there is gender inequality, not in Turkey. There, they paid me the same as my male colleagues. I didn't realize that equality was happening only in my socioeconomic status bracket. So If the equality of women is going to spread all over to all socioeconomic brackets, yes, we can expect wonderful results. But can I expect that if to happen? I don't know. I'd be very happy to see that. On the other hand, what I talked about is very true and true now, as women are catching up with men in terms of having multiple partners. I think the mutual, the symmetric concurrency is going to immediately be reflected in faster spread of sexually transmitted diseases. Thank you.
Judy.
I think Tom was up there first, so
I saw you first, so.
Go ahead, Judy.
This is gender equality.
Gender equality, I was just going to say the same thing.
All right. Well, thank you all for a wonderful morning. Sebke, you've had a lot of questions, so I'm actually going to ask one that goes more to Bob and David. You know, as I think about some of the things that we're learning more broadly related to infectious diseases, there's all the work related to the microbiome. And in terms of the gut microbiome, all these discussions of fecal transplants and retinkering with the quote-unquote normal microbiota in the gut. And so I'm curious, as you think about chlamydia or gonorrhea, what you think about where we need to go with better understanding the vaginal and penile microbiomes, and the potential to think about very new or somewhat new approaches that might pursue those avenues.
Do you want to take that one first?
Yeah, well, I would certainly want to add to that the oral microbiome, because I think that we forget about that, and it kind of relates to the issue of oral sex. I think so I wanted to mention earlier when Sevgi was speaking, because with the HIV epidemic, we had a big problem with sex. So we said oral sex is safe. You can go for that way. And I think a lot of the diseases we're seeing now, the syphilis in the MSM, the gonorrhea in the MSM, and now the HPV oral cancers as well, well-publicized cases recently with Hollywood actors. It does show us that it's not safe anymore. So I think, I'm not really aware of too much data from the throat, but to me that's where, for gonorrhea, I would certainly want to be looking a little bit harder. How we can change it, I suspect for gonorrhea, I don't think playing around with the microbiome is particularly going to be that helpful. I can't see that it would be. I can see in the context of BV or something like that, I could see quite a lot of benefit.
Well, the idiopathic syndromes like NGU and so on also, MPC, PID.
Yeah, so I wouldn't sort of anticipate like great strides with gonorrhea per se.
So I'll be a little bit more positive about the opportunity here. I think one of the early and consistent observations of STIs is that generally if you're susceptible to one, you have several. And this notion of multiple pathogens is an interesting one to understand. And traditionally, it has been explained by the risk behavior itself, exposing you to sources, independent sources of infection, but it might be part of a more general susceptibility pattern that one infection confers susceptibility to another. How this could relate, I think, at a more clinical level is notions of polymicrobial etiology of disease. And I think pelvic inflammatory disease is an excellent one because it is a condition in which many individuals have multiple pathogens which have their origin in the lower genital tract, but they're commonly found in well people without pelvic inflammatory disease. And some of the data I was showing you today about how controlling chlamydia appears to be producing an overall global decline in susceptibility to pelvic inflammatory may suggest that chlamydia itself provides some sort of trigger which allows for organisms in the lower genital tract to spread to the upper genital tract without chlamydia itself doing the actual spread. So I think more studies about the nature of the microbiome among individuals infected with sexually transmitted pathogens is one way to better understand pathogenesis. And clearly it's a route to discovery of new pathogens, as King was telling the story about non-gonococcal urethritis. Also, it has become clear that the development of the immune system in early life critically depends on the nature of the microbial flora itself. And so, given that the immune system produces summations which produce population properties like herd immunity, it would be interesting to relate some of these very important concepts in public health, like herd immunity, to what is the characteristics of the immune system in relationship to specific microbiomes in the gut or vagina, or perhaps even the oral pharynx itself. It's an interesting concept about the penile microflora, because I don't know if much data exists on that, but perhaps uncircumcised men might have a distinctive microbial flora, which would be very interesting to understand.
Thank you.
So outstanding lectures this morning. 3 quick, easy questions. So first for King, to be a little bit provocative, you showed convincing evidence that STIs are increasing in populations, mostly in developed countries. So the rise in syphilis and gonorrhea and chlamydia, as Bob pointed out, the LGV and others. Mostly you mentioned Europe, Canada, the United States, and so forth. And then you showed some slides from Africa showing declines in syphilis and some of the other STIs. Could you explain that difference? Is it an ascertainment difference, or is it that we're doing something different in Africa with the AIDS epidemic that's having an impact on STIs that we're not doing as effectively in the developed world? Very simple question. Before you get to it, the second question's for Bob. And Bob, a very elegant presentation on the chlamydia rise here in Canada. We have the same in the U.S. Interestingly, and the declines in PID, so it's working. I totally agree. Interesting that marked rise did occur concurrently with the introduction of the nucleic acid tests, which are much more sensitive than the tests that you and I trained with. And is that an aspect of the persistence and so forth, that we can better determine it, that it's been there all along, and that some of this is just a reflection of the tests that we now use? And the second part of that question is, when I agree with you, we need a vaccine. The concern about a vaccine is pathogenesis, and that we might do harm, similar to what a natural infection would do. Isn't trachoma perhaps a better way of testing these new vaccines, where we can visually see what damage is happening and quickly intervene? So that's the second question. And then the third for Sevki, very simple as well. You showed there was a genetic predilection, if you will, with the DR2 gene. I'm just wondering, genes can be modified in certain ways through behavior, in fact. And could the internet and other types of external exposure totally modify those people who might be deficient in that gene to behave more in that genetic predisposition to polygamy or increased numbers of sexual partners? So I'll stop there.
Short answers to Tom's 3 questions, please, and then we'll take 2 more, and I think then we'll release ourselves for lunch.
Well, others may have thoughts on your first question of why are some STIs going up in the developed countries and down in the low-income countries. And so this is, I think, there are complexities, but one is that we started at an earlier implementation of antiretroviral therapy in this country than in the lower-income countries, and so just the risk of HIV was substantially different over the periods of time we're talking about in those two settings. I think, secondly, the increases have been seen in developed countries, mostly among MSM, not among heterosexual populations, where rates have continued to be substantially lower than they were in the 80s, for example, and early 90s. Whereas in lower income countries where rates of HIV infection still are quite high, the risks are quite high, there was sort of an absence of any intervention programs prior to what was scaled up in the early 90s, such as syndromic management, such as behavior change messages have had an impact. I mean, one thing you don't see, I've commented to David about this, and his perceptions on this would be better than mine in terms of Africa. But it used to be in the early 90s, through the 90s and even the early 2000s, every place you go in Africa were street signs, practically every street in an urban setting, lots of them in rural settings, use condoms, don't practice high-risk sex. Not there anymore. They've disappeared. And this is true in Chicago. It's true in places in this country as well. They talk about condom fatigue, but I basically think that's the best intervention we've got. It prevents all these STDs, and it's just not being promoted at all anymore in the States. And there's only been one. Patty may talk about this, but the only there have been 2 randomized trials of condom social marketing, something that's been done all over the world for years for reproductive health. One, a small study in the States showed no efficacy in terms of documented increase in condom use. Disappointing, the woman who wrote it did a good study, said it was too small to show difference. But the study that Patty did and led in Peru showed that with a modest investment in condom social marketing, creating some sexy-looking condoms and lots of messages, there was a 20% increase, well, let's put it this way, a 20% decrease in the frequency of unprotected casual sex. And I don't doubt that it's contributed to what she's talking about. So I think some of this early effect was due to promoting things that were easily affordable. We'll see what happens to STDs since that has stopped.
So I just add to that, I agree totally with you about it's comparing apples and oranges if one looks at a population, for example, in the US and maybe a population in Africa, because a lot of the STIs are MSM where you have the big problems, the syphilis, the gonorrhea. And certainly the populations, if you speak to the patients in the clinic, it's MSM are still, on the whole, not presenting to clinics, or if they are presenting, they're very careful about disclosing. So we also see
some of the countries have laws against having same-sex behavior and threats of jail or even death.
So it's about pressure. So you've got pressure from your peers, pressure from your church as well. The religion's very strong effect that's going on in several of the countries, Muslim countries as well as some of the Christian countries. So I think those things have an issue. We also have I think a question as to whether syndromic management is actually driving a selection process for asymptomatic disease. So I've always been impressed when I've gone out and done surveys in asymptomatic men that we find about 1 in 20 of them are positive on molecular testing with good assays that are quality controlled for gonorrhea. I mean, to me, that's huge. But they're not symptomatic, so they're not coming to clinic anymore. And I do wonder over the years if we have made a selection. And then for chlamydia, I think when we see so much gonorrhea, why are we not seeing so much chlamydia, given that most of the West, we see more chlamydia than we see gonorrhea? So why is it we see so little? And it could be, if you follow on from what Bob's been talking about, that it could be that we get so many repeated infections that the immune system is so strong in some of these people that actually they don't come up positive if we look for it. So maybe, I mean, that may be part of the process. So ulcers for sure have gone down. There's no doubt about that. The overall number of ulcers have dropped. And amongst the spread of what's happening in ulcers, we see much less syphilis. And in fact, in Johannesburg, we haven't seen a case of chancroid in 4 years now. We were talking about it. So we've also...
It used to be more than 50%.
Yeah,
so.
that's right. So it's... that's definitely changed. I'm sure syndromic management has had a major impact, but I don't think for the vaginal discharges we've done very much, actually. Yeah.
Well,
So questions that Tom had around chlamydia was, do more sensitive diagnostics go some way to explain the rising case rates that are being observed? And they do. We estimate the magnitude of the effect is probably less than a third. So there still is a large fraction which is unrelated to improved sensitivity of testing. The second question is related to a concern that the immune response elicited by natural infection is involved both in immunity and in pathogenesis. So if you give a vaccine, how are you going to avoid the immunopathogenesis pathway? And that is a tricky problem, and I think there would have to be assurances in preclinical phases of vaccine evaluation that it was safe to bring it forward for human trial. I think whether it's a trachoma vaccine or a sexually transmitted disease vaccine for chlamydia, it is likely that primates would be used as an intermediate model system before vaccines were brought into human trials. In principle, subunit vaccines are thought to be safer than live attenuated vaccines, especially around the question of immunopathology, and that might be an argument in favor of pursuing subunit vaccine design. But I think both of these vaccine approaches look equally promising in my mind and should be compared head-to-head before choosing a single type of vaccine design to bring forward into human trial.
So we have some world-class experts here at the microphones. We should give you quick responses and let you talk.
Okay. I just have one brief question, but first I would like to congratulate all the presenters. I thought they were excellent. And just to you, King, congratulations on your award. I had the privilege of being at your Seattle, Washington STD and HIV course a couple years back. But I know we might be waiting on vaccines, but while we wait on the vaccine, I think we have to zero in on behavioral change. So I just want to come back to behavioral change. And I like the idea of the life course approach and the trajectory. But one thing I wasn't quite clear on is the brain chemicals. And towards the end of your presentation, you mentioned the brain chemicals. And, you know, I'm actually from Barbados, and we have a lot of the...
We could tell that.
The sex...
It's the chemicals plus the reggae music that does it.
The sex tourism, we're definitely seeing it there, even though I thought it was more among the males. And you mentioned the whole idea of females as well. But how do we look at the whole behavioral change in terms of the brain chemicals that you would have mentioned? And that wasn't quite clear to me. How would we address that?
Thank you. That will give me an opportunity to answer Tom's question as well. I think it's important that we not ignore the brain chemicals, which I think we have been doing until recently. However, I don't think we then move the pendulum completely in the other direction and start doing this biological determinism thing. I don't think we need to worry about those who lack the promiscuity, so-called gene, Tom. I think the internet will make up for its lack. I think sex tourism does make up for whatever is going on with brain chemicals. You know, this whole nature-nurture controversy in social psychology has been going on long before, you know, it was there long before I was born, which is quite ancient by now. So we have quite a bit of evidence which shows clearly, no matter what the nature, nurture has its way. So I think sex tourism, Barbados, changing behavioral trends happen despite the brain chemicals. I'm not sure we yet know exactly what to do with brain chemicals, but one study I talked about, which was squirting oxytocin to prevent infidelity, is kind of new, and it may be interesting into the future. There are quite a few people working on treating sex addiction, for example. I don't know very much about that field, but there is some use for brain chemicals, although it's not going to solve all our problems, and it does not explain, I don't think, any more than maybe 10-20% of behavior variability. Thank you.
Well, I might be the only...
You should give your name.
Oh, I'm Kelly McDonald, and I may be the only person who's an infectious disease immunologist with a cross appointment in psychiatry, because I actually have collaborated with psychiatrists who are interested in the neuroimmunological aspects of this very thing. And there's actually a gentleman who's a psychiatrist here in Toronto who's very interested in the concept of sex addiction related to internet porn. And it's very interesting because the idea of watching internet sex and using that as a way of stimulating sexual excitement, it's shown that the anterior cingulate cortex gets stimulated in a way that there isn't the same sort of regulation of sexual gratification that there is with normal sexual gratification. And so that you need more and more sexual stimulus in order to reach the same enjoyment each time. And that is proposed to be one of the reasons why there is younger and younger ages of children required, and more abusive and violent depictions of sexual scenes on the internet, and that these people use more and more time of their day on the internet, and it's a more and more destructive habit that they develop. And so because they don't actually reach the gratification stage of their viewing. So it's actually an area of very intense psychiatric research to try and understand exactly how this type of addiction is developed and interventions for it. So I think that it is a very important area for us to study, because in and of itself it is actually quite a destructive thing in people's lives. And it ends up I think it's quite different from some of the other factors in terms of core groups and the right tail and that sort of thing. But there's an actual very valid and important field of study going on here. I might also say that I was actually the medical student struggling in the casino clinic when King came to Nairobi in the 80s with another fellow that Alan Ronald was supervising, and he took about 1,000 pictures of chancroid ulcers, and then he actually dragged me back to Seattle to work under his tutelage, among others, during the late 80s and early 90s. But I'd like to ask the people on the panel two very closely interdigitated questions. I do research in non-human primate models, HIV vaccine research, but have worked with STIs and HIV in an integrated way. And we have the opportunity in those vaccine models to actually work with STIs, because macaques in particular are susceptible to many of these STIs like chlamydia, gonorrhea, and SIV. And so there's the opportunity to model the risk of infection induced by these STIs in the non-human primate. But we also have the opportunity to look at how the microbiome is altered. And one of the people in this audience, Rupert Call, Judy Wasserheit, you could speak to him, because he has actually done some very interesting work looking at the penile and vaginal microbiome on this subject. And it may be we need to take more of a programmatic model, taking from the clinic what we really see as the interaction between these things, in trying to understand how the the interaction between these pathogens occurs to make individuals so susceptible. And I wanted to know how the STI community can be more influential, both not just as you've promoted in terms of funding STI research, but in terms of making people aware how much this influences both in trials for HIV vaccines, but also susceptibility for HIV worldwide, that both PEPFAR-funded studies and programs, that this is a continuing issue in terms of understanding the pathophysiology and biology. And King, maybe you can start that
King, can you respond briefly?
I think that Harlan Caldwell is working on primate models and interested at least in more work in primate models as he moves from the ocular vaccine that he's now evaluating with Tom Quinn, could probably say something about that too, to genital chlamydial models. So I think all of your comments were pretty relevant. I think it's interesting to think about I guess the animal models, what E.O. Wilson would be telling us about what we could learn from how animals are mating to what factors do or don't determine what is the nurture part of it as opposed to the genetic part of it. But I think I'll stop there and let Michelle.
Michelle, you have the last brief question.
It's a question to Bob Brunham, and it's a bit in line with the question from Tom. Okay, so that there's a bit of the explanation in the increase that is related to the switch to EIA test, let's say to PCR, in the increase in chlamydia over time. But more recently, and that could explain what happened part of what happened between 97 and 2002, 2003. But the last 8-10 years, most places use nucleic amplification tests. We still have an increase. But what we have seen and what has been published from some places as well is that the positivity rate for chlamydia in people tested in clinical care hasn't changed much. So how do you reconcile that? Because we see, the prevalence of chlamydia basically is the same in people tested than it was 15 years, that it was 10 years ago. But we have, and does that still support that hypothesis? Although I believe in it, the immune thing, and one of the reasons I believe in it is that in places I work, the prevalence of chlamydia in sex workers is the same as in the general population, whereas for gonorrhea is 20 times more in sex workers.
So basically, Bob, have you adjusted for the difference in sensitivity of the tests?
We have.
No, but volume of tests.
Right, and that really relates to the screening program. What are some of its characteristics? How much of the ideal population is being screened appropriately for chlamydia infection? We screen about 30 to 40% of all individuals who would qualify by our criteria annually in British Columbia.
Females.
And that
Females.
Right. So it's focused really on young females less than the age of 25, and that proportion has not changed over the past 3 or 4 or 5 years. So that's partly goes to the explanation of why we think, or why I think, immunity is a dominant force in shaping the epidemiology of chlamydia during an age of control. So scaling up to screen all eligible women, this has been a public health perspective that really the nature of the rising rates really indicate that we should be screening more individuals. I think that's still an open question. I personally think we have run into an immune barrier, but I'm willing to concede that it is still an important question to ask.
Okay,
I have 2 quick questions that you sort of nodded. So quick answers. David, for you, you noted the differences in recommendations for ceftriaxone, 250 in the States, 500 in the UK, I don't know what it is in Canada. 250. So you implied that we should be, that higher doses may prevent the emergence of resistance, that in the STD field we've been too cautious. So the question for you is, shouldn't we all be recommending that we switch to 500? And I ask this partly because David and I are working on a paper together where we're going to be making recommendations on that. And for Bob, should we or should we not continue screening? What was the amount of money that was spent per year on this in British Columbia?
About $10 million a year.
$10 million per year. Yeah. And so we're presumably preventing PID or reducing risk of PID in ectopic pregnancy, but reducing herd immunity. So should we or should we not continue the screening program? Or, given your broad perspective on public health, are there better places to spend it?
Okay.
Brief answers.
Okay. Yeah, so it wasn't so long ago as well that it was 125 milligrams for ceftriaxone. So, but what I will say quickly is I think we should have an international agreed figure. 500 is what's in Australia and the UK. In Japan, it's a gram, and I believe in China it's a gram as well, given intramuscularly, and I think some of the clinics give intravenous 1 gram in Japan. But what I think is really important is that there's 2 bits of evidence come out now. One from the United Kingdom, Kathy Eisen wrote a paper in Lancet Infectious Diseases this year, and also from Japan, it's currently about to be released in press.
Some drop in MICs.
Yes, and they've shown basically since the higher doses have been given in both those countries, there was 0 with decreased susceptible strains for cefixime in Japan, 0% of the strains above 0.25. So that shows a reversal, and we've also seen a reversal in the UK. So it does suggest if we go for the stronger agent, and I'm very interested in Botswana. No one's done any work recently, but they've been using it for over 10 years.
500?
I'm not sure, I think it's 250. Of ceftriaxone, and there's certainly been no verbal reports of any problems with resistance there. So it may well be that we've done ourselves a disservice with the oral cephalosporins.
So with respect to chlamydia control, I think we should continue screening at the level that we are screening, but we should refocus from scaling up the program and putting more resources into screening to coordinating and